Okay, so good afternoon, everyone, and welcome to this afternoon session entitled Challenges and Solutions in Expanding TAVI World. This is a live educational session, including a live case from Clinique Pasteur in Toulouse. And the session is sponsored by Medtronic, and you can see here the team. My name is Mohammed Abdel Wahab. I'm from Leipzig, and I'm moderating the session together with my friend Dan Blackman from Leeds. The operators will be Nicolas Domontil and Didier Cheche, and we have a panel including Nicholas van Meegem, Danny Dvier, Magdalene Erlebach, Katharina Gondolfo, and Ole de Becker. And the objectives of the session are to understand the most recent evidence in low-risk patients with aortic stenosis undergoing valve replacement. We want to learn how to overcome challenges in lifetime management in patients considered for TAVI, and also to appreciate what we currently have as innovations in both technique and technology for revalving procedures. Dan?
Yeah, thanks, Mohammed. So we want to make the session interactive. It's quite a big room, which often makes it a little bit harder. But we've got microphones. If you look in the aisles, there are microphones. You can go and ask questions from the microphone, but also use the app. Any questions you put through the app will come to me, and then we can discuss that with the panel. We want to make sure that we're giving you the information that you want rather than what we've just prepared. So please feel free to interact. So we'll get going with the session, and we're going to start off by looking at TAVI in low-risk patients and what the long-term outcomes are. And we're mainly going to do that through a panel discussion, but to make a start with that discussion, Magdalena Erlebach is going to give us a few slides with some recent data in that field. Magdalena.
Thank you. Oh, thank you. Actually, a few slides is maybe a little bit exaggerated. I'm going to sum up what we all know from the Evolut low-risk trial 5-year data that were presented last year. The primary endpoint with all-cause mortality, disabling stroke at 5 years in low-risk patients showed no difference between Evolut or TAVI and surgery. And there was broken down into non-cardiovascular and cardiovascular. There were also no differences between Evolut and surgery, but you could see an unproportional rise in non-cardiovascular mortality between 4 and 5 years for the Evolut group, and you saw a rise in the delta between surgery and Evolut in regards to cardiovascular mortality.
So maybe, Magdalena, sorry to interrupt you already.
Yeah, that's perfect.
But we want to make this interactive. We want to have a discussion. So we were talking about these data, and Nicholas, we had a little discussion and debate about what these mean. And there's been, I think it's fair to say, there's been a lot of speculation in these low-risk trials about these survival curves, these primary endpoint curves. Was there a difference between TAVI and surgery? Are the curves coming together? Are we over-interpreting this? What do you think about that story about the curve we see in front of us on mortality and stroke with Evolut versus surgery in the low-risk trial?
Well, as a scientist, I think there is just no difference between the two treatment strategies, and I think TAVI is really living up to the expectations, in my opinion. The bar is very high with surgery in low-risk patients, and TAVI is addressing that bar. So I don't feel that we can say that there is a difference. And you see these curves, they follow these waves, but I think we should not over-interpret cardiovascular and non-cardiovascular mortality and analyzing these Kaplan-Meyers.
Magdalena, any differing view from you?
No, I have to say I agree. I think what we can see is that there is no difference to surgery in low-risk patients. So TAVI is performing very, very well. What these differences exactly mean, I don't know. I think it's reassuring that the cardiovascular mortality is not rising in TAVI due to pacemaker or whatever all the worries are that we do have. But I think it is maybe a little bit early, but we can say at 5 years it's good result.
Yeah, I think that's fair. I mean, I think it's a great example of how we get drawn as clinicians into over-interpreting small, non-significant differences. And if we discussed earlier that if a trialist was here, they would be tearing their hair out saying, there's no difference here, guys. Yeah. Look at the p-values. But that's good. The outcomes are equivalent. Do you want to move on? I know you've got a few more slides.
Sure. What was recently presented at AATS just a few weeks ago was data on the bioprosthetic valve dysfunction in the same Evolut low-risk trial, 5 years. And again, here there was no difference between Evolut and surgery. But what was seen in surgery, in TAVR, pooled data, everything, that if patients do have bioprosthetic valve dysfunction, then there is a clear, significant influence on mortality. And when we talk about bioprosthetic valve dysfunction in recent studies, of course, we can jump right to the SMART 2-year data. The clinical endpoint between SAPIEN and Evolut, the comparison in small annuli, the primary clinical endpoint, mortality, disabling stroke, or rehospitalization, showed no difference. But when we look at bioprosthetic valve dysfunction, there was clearly a significant difference with 12.5 and 48.4, mainly driven by severe patient prosthesis mismatch and elevated gradients.
Okay, so that brings us on to another really interesting area. Ola, maybe I can come to you on this. I mean, so in SMART here, we're seeing a huge difference in bioprosthetic valve dysfunction, but at 2 years, no difference in clinical outcomes. If we look at the 5-year low-risk trial, we see no significant difference in structural valve dysfunction, but we do see that the bioprosthetic valve dysfunction is a predictor of increased mortality. So can we read from that we're going to expect to see a difference in harder endpoints like mortality in SMART? And if so, when might we expect to see that difference appear? What's your perspective?
That's a very hard question to answer because we don't have the data to answer this, if I'm honest. And this BVD, so to make it clear, BVD is an assessment that's made right after the procedure. So this is nothing about how good the valve lasts or the durability. This is a snapshot from right after the procedure, yes. It's about hemodynamics. Hemodynamics measured with echo, because that's then another discussion if you want to open that discussion, whether it's echo measured gradient. You don't measure gradient, but you actually measure flow there, or do you go for invasively measured gradient? There, Nicolas van Michem has some very nice recent data published in your intervention there. So I think we have to wait to see whether this translates in SVD over time. So maybe more stress on the leaflets, more earlier valve deterioration, and whether that then even translates into clinical endpoints, we don't have any data on that so far. Even up to 5 years, I would say, if we look to the low-risk trials.
And I guess, notion at 10 years, we see something similar, Danny, where there's a difference in hemodynamics, bioprosthetic valve dysfunction, but it doesn't seem to, even at 10 years in notion, have translated into
and none of us would monitor 15 years, right, or 20 years. Eventually, this is what we need, but it will be difficult to show.
Well, look, but then maybe, there was something I read yesterday, I think, even on a comment of some other study which was just comparing some other valves, and the end discussion was, if you can choose between two platforms, they're equally good, even clinically, but you have the better hemodynamics, you can go for the one with the better hemodynamics. Why would you let the doubts kick in there? And so that's another point of looking into it. If you have, this is all in small annuli. So if you want to take away the doubt or hesitation you have, you can go for the valve with the better hemodynamics. That could also be a take on it, even if they're clinically equal so far.
Yeah. So I think the limitation we have in all the trials we have is that they are still including patients that are elderly. And these patients, they have a limited life expectancy, and there will be a lot of noise during follow-up of these patients that prevents us from picking up the exact impact of, for example, hemodynamics or things that are related to the valve, related to the prosthesis, and getting all this noise out during a follow-up period of these elderly people is extremely difficult. But nevertheless, and thank you, Magdalena, for highlighting these data, we'll move forward to Nicolas, because even if we're not sure TAVI is better than surgery or surgery is better than TAVI, probably both are equal, and which valve is better, we are still faced in everyday clinical practice with a decision we have to make in a patient, how to treat, which modality and which valve, and does it matter? So, Nicolas.
Thank you, Mohamed. I wanted to add more perspective on structural valve degeneration, or maybe on valve failure over time. And I wanted to do that by looking at what we know from recent data in the literature. And this is from the Sweetheart Registry, where they were looking at outcome of patients who received a surgical bioprosthesis. Now let's see the low risk in blue, in red, the intermediate risk, in black, the high risk patients. And what happens at 15 years? Well, the majority of patients are dead after 15 years. And this is a reality. Aortic stenosis is a disease of the elderly. So if we need to wait 15 to 20 years to see the difference or the impact of bioprosthetic valve failure, it's clinically not relevant. Look at the age. That is a different story. So the life expectancy increases, obviously, when you're younger, when you receive the valve. So at age 65 years old, there's a big difference between the low-risk patients and the intermediate and high-risk patients. But if the patients are at an older age, there's no longer a very clinically meaningful difference in survival between these three risk categories. And let's look now at the age when a patient receives a surgical bioprosthesis. Obviously, when you're very young, when you're only 50 years old, then you almost have a 50% chance that one day you will need a re-intervention for a degenerated bioprosthetic valve. But at age 60, only 1 in 4 of the patients will eventually end up with a re-intervention. At age 65, it's 1 in 5. At age 70, it's only 1 in 10. So keep that in mind when you discuss with your patient. It is not a guarantee that this patient will require a next intervention and will outlive their valve. And this is basically a calculation, an estimation done by Philippe Généreux and his group, where they looked at what's going to happen in the forthcoming years. And you see a small increase in the number of failing surgical valves, but you see a steep increase in the total volume of transcatheter valves. Obviously, that is because transcatheter valves are now more commonly implanted than surgical valves. But this is what to be expected. So in 2028, we will be doing more TAV in TAVs than TAV in SAVs. So when you do an analysis for those patients, and this is already anticipating the procedure that we're going to witness from Toulouse, then what to do in terms of planning? Well, I always focus on the root dimensions. That is a very important aspect, and also the coronary arteries. We need to know how the coronaries are relative to the root anatomy, and I think the value of conduction in a failing surgical prosthesis is less relevant. In the workup, I would recommend everybody to at least consult this app by Vinny Bapat, where it becomes very easy to understand the surgical valve that has been implanted. There are 3 types. You have the stented, the stentless, and the sutureless valves. And with sutureless valves, you have to ask yourself, why on earth has that been developed? Because that's a TAVI that is being implanted with open heart surgery. Stentless valves, that only makes our life difficult if it degenerates, because it's hardly visible. So I would definitely be in favor of surgeons using only stented valves. So when you look at the sizing for a revalving procedure, you can base yourself on the charts, on the expected dimensions that you get from the manufacturer, but you have to be careful, because sometimes the surgeon makes a reporting error, says we implanted a perimount 23 and turns out to be a perimount 21. That happens not just once, multiple times in our practice. So that's why I always rely on CT scanning. I always want to measure by CT what is the actual dimension of this failing surgical valve before I make my decision on which transcatheter valve is required. But also there is a caveat with CT quality and blooming artifacts that may make CT analysis a little bit challenging. The app also gives you, based on the sizing, the option of the transcatheter platforms that you should consider. And we'll get to that in more detail later. And then in terms of coronary obstruction, yes, coronary obstruction is more common in a TAV and SAV procedure than in TAVI for native valve anatomies. That's clear. And also our colleague, Dr. Ribeiro from Brazil, also looked at when you have a failing surgical valve. When is it more common? It's more common with stented valves with externally mounted leaflets. So the mitral flow and the trifecta valves are notorious for this, but also this stentless valve is a sucker, in my opinion. So it also is associated with more coronary obstruction when you do a TAV and SAV. I think there is a lot of potential in simulations, in pre-procedure procedural planning, implementing simulations, because it gives you a unique visual, and you start to understand how the valve will be seated in any given anatomy relative to the coronaries, but also the association of the coronaries relative to the sinotubular junction, the sinuses of Valsalva. I think this is a potentially very clinically relevant tool that we are exploring. And as a matter of fact, simulations can also be used to simulate lifetime management. So what would happen if a patient starts with one valve and then requires a second valve or a third valve? Now, we did a couple of simulations, and what you see is that the valve area by itself is declining. So with 5% when you go from native to a first valve, with another 20% up to 30% when you would insert a third valve. So prosthesis patient mismatch guaranteed. So that is why we should not, or we should keep our surgeons as close friends, because we will need surgery also as a treatment option for our patients. So to conclude, expect an increase in failing surgical, but also transcatheter bioprosthesis. Consider the root dimensions, the bioprosthesis type, and the coronaries when you are doing your planning, and consider simulations as a complementary tool and also for lifetime management considerations. Thank you for your attention.
So thanks, Nicholas, for this great and precise overview. So I want to go back a little bit to the consideration or the question, which valve to start with? TAVI versus surgery, self versus balloon expandable. When you face, Danny, a patient that is more or less early 70s with a small annulus, and you have to make a decision making first between TAVI and surgery, and then talk about the device type.
Well, it's a very important question, and we need to really introduce the concept of doing imaging before all options in severe AS, because some of our surgical colleagues think, oh, okay, this is a patient for surgical AVR, and we don't need to know the anatomy. And then they face the patient in the operating room, understand that they can put only a 21 or sometimes 19 valves, and say, this is what we can do. This is what we can do. And obviously, a patient with a small annuli needs to be known before the procedure. It needs to be known. And obviously, we know now. We have a lot of data to suggest that supraannularity, better hemodynamics, is translated to better outcomes eventually, less severe PPM. We need to understand who are these patients and to obviously choose TAVI and choose the correct valve during TAVI for these type of patients. For early 70s, it's clear. For mid-60s, early 60s, maybe it's different. For mid-50s, maybe then it's a mechanical surgical valve.
But Ola, there are, of course, concerns. I mean, we are in a sponsored session by Medtronic, but there are concerns that when you start with a tall frame valve, that you may have issues with coronary access, with maybe re-intervention. But does the evolution in our technique and importantly technology, did it neutralize these fears or not?
I think largely, I mean, look, we have seen a big evolution from a couple of years ago to, if you talk then about the Evolut platform itself, we are becoming much better in commissural alignments. It's proven in 90-95% of cases, if we do follow the appropriate steps, we end up with a proper commissural alignment. That's one thing, and that's the biggest predictive factor typically for a failure of getting into the coronaries later on or getting trouble in a revalving scenario. So commissural alignment is successful with this platform. Now we have with the FX Plus, the Evolut FX Plus, the novelty about it, not only that it's more flexible, because it's only one spine instead of two spines, so the catheter is really 3D flexible, but you have on the valve itself, you have bigger windows. Yes, so there where you had in the past, in between the two commissures, at the height of the coronaries, nicely, where you had 4 cells, you have now 1 cell. Yeah, so this all facilitates coronary access for sure. And also the commissural alignment is very important. If you have revalving cases, which I've had, the most important for me is to see immediately, is there commissural alignment in my index TAVI, yes or no? If there is commissural alignment, I can typically bail out with any valve. You always find a solution, whether you have to do leaflet modification, yes or no, but there's always a way out there. So I think there has been a big evolution, and also how I look to this field, and also which valve to use in maybe younger patients, etc. Yeah.
So Magdalena, like cardiologists are making things sometimes overly complex, so we're thinking about which valve to choose. We want to do commercial alignment, we want to think about hemodynamics, we want to have coronary access reinterventions. We're thinking about a lot of possibilities in the future, even if we're treating patients that are elderly. As Nicholas mentioned, they may not require all these three interventions, but still we are thinking about these options. Is a surgeon doing the same?
I think it's changing. So Danny mentioned CT. So we've established, I believe, and also many other surgical centers, that you need a CT pre-op, not just to test which access you're going to take, minimal invasive or not, but also because we want to know the size, and we're thinking about root enlargement. I mean, new techniques for root enlargement have started. I mean, one of the biggest things was that root enlargement is said to be extremely difficult as it was previously performed, and so new techniques are coming. So I think the awareness that what needs to be thought about is also spreading to the surgeons as well. Root enlargement, what valve has maybe better hemodynamics, what is not so good maybe for a valve-in-valve as well. I mean, and before trifecta was gone, of course, we did think about do we want to implant the trifecta because it could be a problem. So I think it's becoming more and more common for surgeons to also start thinking more complex.
Okay, great. So to summarize maybe at this step before we go into the details of the live case, so the data we currently have after 5 years in low-risk population, and we've seen the data from the Evolut low-risk trial, are extremely encouraging for TAVI compared to surgery. We have now randomized data in a subset of patients that is a bit more challenging with small annuli, where we see some advantages for the supraannular platform in terms of hemodynamics. We want to see the impact on long term because this will help us in our initial selection of valves, which is becoming quite complex. The younger the patients, the more complex is the way we think about the initial strategy, because these patients may need a revalving procedure at a certain time point. So, Dan, would you like to present the patient that has been prepared by Toulouse?
Yeah, thanks, Mohammed. That's a great setting of the scene for the case that we're going to see from Toulouse, which is a valve-in-valve TAVI. We've been talking about not just choice of TAVI valves, but also surgical valves in younger patients. And this is a patient aged 78 who's been admitted to Toulouse, to Clinique Pasteur, with structural valve deterioration of a surgical valve with stenosis, with NYHA class 3 breathlessness. Patient has a background history of PCI to the circumflex. Surgical AVR was performed in 2014 with the Intuity 23 millimeter sutureless valve. Comorbidities include hypertension, dyslipidemia, cigarette smoking. BMI is pretty good for our patients. The patient is relatively sedentary but still independent. This is the medical therapy, unremarkable. Labs, also unremarkable. Significant elevation in BNP, EGFR down, but not prohibitively so. Echo showed a near normal LV function, low normal. Significant structural valve deterioration with stenosis with a mean gradient of 39, peak velocity over 4 meters per second, indexed valve area in the severe range, and with associated significant pulmonary hypertension, but no other important valvular disease. Here we see the angiogram, which broadly speaking shows atheromatous coronary arteries, but no significant epicardial stenosis. So no thoughts for revascularization. So Nicholas showed us the app before, and this is an essential part of our procedural planning for pretty much all of these TAV and SAV cases. So here we see the Intuity valve, and a really important indicator on the left here, when you look at the fluoroscopic markers, we can see that this dotted red line marks the sewing ring. And what's different from this and the standard surgical sewn valves is this stent frame that sits down in the left ventricular outflow tract. This is not our landing zone. This is our landing zone, the sewing ring, just as it is for all other TAV and SAV procedures. So we need to know the dimensions, as we do for all these surgical valves, and the app tells us the true ID, which is what we predominantly base our sizing strategy on, is 21 millimeters. That this is a valve that can be fractured, although there's minimal experience and therefore no guidance given in the app on what size of balloon might be used for fracture. So in summary, we have a 78-year-old, severe aortic stenosis due to structural valve deterioration of a sutureless bioprosthesis, a stented bioprosthesis with a Euroscore logistic of 31%, Euroscore 2, 6%, STS score 4.6%. So an interesting case and something that many of us don't have much experience of treating these degenerated sutureless valves. So Mo, I'll hand that over to you to lead the panel in a heart team discussion.
Yeah, so let's dive a little bit maybe deeper first into the images that we have. So Ole has prepared some analyses he did for the case.
Yes, we got the CT to analyze. So that's interesting to have a look at this CT. So this is the intuitive valve, as you saw. So it's, in a way, so you have these stented, stentless, and sutureless. So this is a sutureless valve, but it is also, there's a stent. So there's this stent part. Just as you know, most of you from a Magna-Ease, it's almost exactly the same, but it's prolonged with a steel skirt. That's why the surgeon could implant this without suturing, and it's sutureless. It's in a way, as Nicolas said, it's kind of implanted like a TAVI in this structure, but it's a surgical bioprosthesis. It's a 23, it's important indeed to check, as Nicolas also mentioned. Don't be surprised that sometimes it doesn't accord with the surgical report, so it's super important to check this. This was reported as a 23, it looks indeed 23, there's some blooming here, clearly, so this confirms it's a 23 intuitive with a true inner diameter of 21. Here you see we're going up, so just to show you the aortic root and how much space you have to the coronary, here we see the left main popping up, and we have immense distance to the left main, and the right coronary is even taking off above the top of the surgical commissural posts. So I'll let it play again, or I can take this here to go a bit slower. So here I come at the level of the left main here. So the left main is around, first of all, quite high, 20.6 millimeter height, and you see there's a massive distance. Typically, we only start to be nervous if this becomes less than 4 millimeter. Here we have more than 10 or 15 millimeter. And then the right, we don't even see. If we go above the commissural posts here, then here on the top at 12 o'clock, we see the right coronary taking off. So in summary, and also you can see, of course, the aortic root has a little bit of an aortic, horizontal aspect, not much, but kind of a 60 degree. So to summarize, the coronary risk, which is always something which we're nervous about if we do a valve in valve, whether it's TAV in SAV or TAV in TAV, this is something you have to rule out, that the coronaries are not in danger. They can be in danger because of pure coronary mechanical obstruction, but also in some anatomies, there's no risk of coronary mechanical obstruction, but of sinus sequestration. That's because you push the leaflets of the first valve on the side, you create a longer nail skirt, and if this risks to touch the ST junction, you close off all the blood supply in the sinus. So this is another, there are two different mechanisms of coronary occlusion. But here you see this case is not at risk, not for mechanical obstruction. You see here 18.7 millimeter distance, and the right coronary, the coronary risk plane is above the neoskirt plane. So these coronaries should totally be fine. Then what we also get out of the CT, very important, are the views. Most of you know tricuspid coplanar view, cusp overlap view. Here, because you have to revalve a surgical prosthesis, I would almost like to take away these terminologies. You have to look at this a little bit differently. Of course, you can make an S-curve. Clearly, you make an S-curve of this particular patient, of this particular surgical bioprosthesis. But what you're interested in is to have a view where one of the commissural posts of the surgical bioprosthesis is isolated on the right-hand side. The two other posts are superposed on the left-hand side. This is kind of an, well, NCC, it's a kind of a right-left cusp overlap view still, but you isolate the non-coronary cusp here. The right and the left cusp are overlapping of the surgical bioprosthesis. So here, this is an REO 11 and caudal 33. But most important to know, an REO 11, they can confirm this, of course, during the case on their fluoroscopy, which is easy to do. The tricuspid view, typically you don't particularly use, and then you go for the isolation of the left coronary cusp, where the left main will take off. And this is an LCC isolation view. This is, in this particular case, an LAO 18, cranial 18. So for me, going into the case, of course, I can double check on my fluoroscopy, but the only two angles I'm interested in is my REO 11 and my LAO 18. And I will take my parallax out in my Evolut valve, in either my REO 11 or my LAO 18, and that's the two views I kind of will use. I know there's other implantation techniques possible, but that's probably the best. Also, if you want to get commissural alignment, and that's important here, if the Toulouse team wants to take the full advantage of this Evolut FX Plus, which has these nice open large windows, it only pays off if they implant it also commissural aligned with the commissural post of the surgical valve. Yes. Then here you see the arch. Of course, there's no acute angulation. There's some calcifications. You have that little bit of horizontal aspect. One other thing you might anticipate, I don't think they will face it, but because the sinuses are so large and you have a surgical biprosthesis, theoretically, one of the challenges you may face is that it may sometimes be harder to cross the valve. Yes, because you have very wide sinuses and a narrow surgical biprosthesis, so it may be in some cases that you need maybe a stiffer wire like a Lunderquist wire. I don't think here, because it's especially very wide open sinus to the left coronary cusp, the post and the frame is more closer to the outer curvature on the non-coronary cusp side. So I don't think they will face a challenge crossing this surgical valve, but you never know. And then the access seems fine. So this you've seen before. I just want to stress again, this is so what the aim will be. I think they will repeat this, Didier Tietche and Nicolas Dumontet, that you have to kind of ignore this steel skirt in the LVOT. This is not your landing zone. You really try to focus on this real stented part of this surgical biprosthesis. And then what the app also recommends is that you implant this Evolut at roughly 3 millimeter, the classical depth, yes, with the markers here at this kind of new annulus or base of your stented valve. And then this is the final slide. In a way, in order to get the optimal hemodynamics, this is from Danny Dweer from a couple of years ago, from almost 9 years ago, I see. So he did bench testing, and to get the full benefit, again, of the Evolut and the nice hemodynamics of the supraannular leaflet position, you also want to have a reasonably high implant of this Evolut. You come away typically with a lower Evolut implant too. If the Evolut would go down and you would have a lower implant, I'm sure there will not be PVL, but you will not have the full hemodynamic benefit because the leaflets will be kind of constrained in that narrow part. And there will be some leaflet pinwheeling. So ideally, if they can obtain a nice high implant, they will do the best for this patient. Okay?
Thank you, Oli. So this was perfect. Katharina, maybe, I mean, this is a kind of an unusual valve. I don't think we have a big experience in treating. Did you treat an Intuiti before?
No, never. I don't have experience with this kind of valve, and so many data probably are missed. I don't know if, for example, in this case, it could be advisable to do pre-dilatation before or protect, do some neurological protection. We don't have too much experience to treat this kind of valve.
And what would you recommend people to do if they are facing a valve that they never treated before? Just do it, or do you like ask your friends? Do you call Danny or look at the app?
Yeah, why not?
Yeah. Ask the surgeon, maybe. What do you recommend?
A deep analysis of the imaging, of course, and also with tailoring the implantation in the patient, as Ole showed us. And why not also some opinion from very expert operator.
Ask friends and relatives.
Mohammed, can I come in there? 'Cause I just think it's a great point, because I think what we most of us see is that our surgeons use particular valves.
Yes.
So we're the world experts in treating mitral flows, which is not something you want to be.
Yeah.
But when we've had, Sorin Biofreedom came along, we hadn't done one at all. So, but we knew that there were other centres in the UK where that was a popular valve. So there usually will be a centre not too far away where a lot of those valves were put in, and therefore those interventionists have got used to retreating them.
Exactly. So asking for help is advisable. But Magdalena, as a surgeon, how often are we going to face these sutureless valves? Like how often have these valves been implanted? Are they still being used or not anymore?
I think the sutureless valves, there are people that love them and people that hate them. And I think there are more that don't like them. We used to use them. We found it a little bit difficult, the sizing, the question of oversizing in regards to PVL, and then the pacemaker rate were quite related. Hemodynamics are good, but the time that you lose by suturing is not that much, because you have to cut out the valve anyways. You actually put 3 stay sutures for the Intuity, so we did use it. We did implant it a few times. You put 3 stage sutures, so I mean,
so
3 or
sutures. Yeah,
there are 3
The formal name
sutures.
is rapid exchange valve.
Rapid deployment.
Rapid deployment.
Rapid deployment.
Yeah, rapid deployment. Yeah, so there are 3 sutures. So if you put 9 more sutures, there is a little bit of a time difference, of course, but I don't think it's that relevant. And now using Coronary, for example, we just shoot these sutures in. We don't have to time anymore. So I think they're not being used that much, but we will see a few cases, for sure.
Can I make a point, though? Sorry to keep interrupting, but I mean, we often castigate the surgeons for using valves that turned out to be rubbish, like trifecta, MitraFlow. Sutureless, we're saying now there's no data. But when we treat young patients, do we always use TAVI devices that have long-term outcome data? I'm not sure that we do. I mean, we certainly try to do that in our centre, but there are plenty of TAVI devices out there with not much data and certainly no long-term data. So I think we also need to think about what we're doing when we're treating patients with long life expectancy, and don't go for valves where there's proven evidence of long-term data, rather than risking ending up in the same situation the surgeons found themselves when they went mad for trifecta and MitraFlow.
I totally agree. So Nicholas, obviously they're planning to use an Evolut device. Any advantages for the FX Plus for a revalving procedure? Any disadvantages in your opinion, or is it like?
I think it's a very good valve, also with the future in mind, because of this large open window that you now have for coronary re-access. Coronary accessibility and the risk for coronary obstruction are real items that you need to consider upfront. And I think it's well covered when you're considering an Evolut FX Plus. So you really should be able to re-access the coronaries if you follow the instructions for use and you're respecting the commissures. So I think it's a good option.
Ole, you analyzed the CT in details. It looked to me as if this valve could have been initially bicuspid. Like the way you look at the coronaries, they're opposite each other. The sinus is big. There's some aortopathy. So is this something where you would think maybe of coronary instead of commissure alignment, or no?
No. I mean, that coronary alignment, I don't think you should go for that. I mean, especially here, there's a surgical bioprosthesis with commissural post there. So you should absolutely respect these commissures of that surgical. You should not go for coronary alignment. By the way, if you go for coronary alignment, 2 small things before we go then live. I mean, we've studied this. If you want to do that and the implantation, it only affects that you have to go even more arteriocaudal than the right-left cusp overlap view, which brings you in a sometimes impossible view with your C-arm. That's one thing. Secondly, your left main is almost in 99% of your patients very central, taking off from the left coronary cusp. But your right coronary ostium is very often more eccentric, more to the RCC, NCC commissure. So what does it mean? If you want to really push the commissure of your new implanted device in between the 2 coronaries, because that's kind of coronary alignment, you optimize maybe your access to your right, but you make it more difficult for your left. And typically your left coronary is the more important one. So, but then especially in this case, I would say no, you want to go for your commissural alignment with the surgical bioprosthesis.
So clear answer. So they're ready in Toulouse. So Let's briefly show the operator strategy. As mentioned, the case will be done by Nicolas de Montil and Didier Tchétché from Clinique Pasteur. The strategy that they prepared is they're going to do the procedure under conscious sedation, an echo-guided puncture of the right common femoral artery, a single pro-glide pre-closure technique. They opted to use cerebral protection, which is something that we didn't discuss, but we'll definitely can do afterwards. They've chosen Evolut FX Plus 26 millimeter, and they are planning a post-dilatation of needed. This is the interventional team. You see the operators mentioned, and the whole nursing team, the anesthesiologist and the radiographer, and the medical coordinator is Bruno Farah. So if the team in Toulouse is ready, so good afternoon, Nicolas, Didier, and the whole team. We can see you, and hopefully you can see and hear us.
Welcome back to Clinique Pasteur for this live demonstration. So we heard your great conversation and the analysis of all the challenges of the case. You've introduced the team. So I guess now what we can do is to go through a step-by-step deployment of the strategy that we have decided, Nico. It's a challenging in the sense that it's a kind of new degenerated surgical valve that we have to treat, and we need to gather knowledge about that. But could you tell us where you are in terms of patient setup?
Yeah, thank you, Didier. So as you guessed, we have already started to treat our patient before you join us. You described the setting. So the main arterial access has been done through the right femoral groin, as usual, with a conventional routine technique you described. You've just described and discussed that, and we acknowledge that there is no data to support routine use of cerebral protection, but still in some selected cases it could be discussed. So we will have that for discussion maybe at the end of the case. Here is the visual signature of a valve. I think you already seen that. This is live confirmation of the predicted Didier cusp overlap view by the CT scan, arrow 12, caudal 40, where you see at the right of the image one post of a surgical valve, while you have on the left the two other ones superimposed, and we've heard that you described the signature. So the crossing that could have been challenging, we never know, in a stenotic degenerated valve finally was standards. We used a straight 035 wire. And here where we are, Didier, we have a pigtail inside the LV. You have a live recording of the LV aortic pressure. And we are ready to insert the Safari and keep on carry on with the procedure.
Yeah. So there is the peak-to-peak gradient is about around 30 millimeters of mercury. The patient is under conscious sedation, but at least we have our reference, our metrics in terms of heart rate, about 50. The diastolic aortic pressure is about 40. So a little bit low, and the end-diastolic LV pressure is about 15. So this is where we are. We're going to proceed, Mohamed, with the insertion of the Safari. It's going to be a Safari small. The ACT is above 250 for a patient. So we are ready to proceed with the first step that is going to be the deployment of the stiff wire. And then there is also always that discussion if you are dealing with a valve-in-valve procedure, whether or not to proceed for either a pre-deal or even a balloon fracture for fracturable surgical valves before the deployment of the THV. So we are kind of interested in hearing your thoughts, Mo, Dan, about the timing of a potential fracture or stretching, reshaping of the surgical valve. Would you do it before or after?
Yeah, thank you, Didier. So we were actually a little bit debating about whether the valve is fracturable or not. Then we realized that the app says it's fracturable, but I think none of us has experience with fracturing this type of valve.
The ring is not conventional, this valve, because in the way it's implanted, it's stretchable, but you don't need fracture in this case. Actually, in general, the group of sutureless valve-in-valve procedures are less prone for residual stenosis than conventional patients. They resemble in some way the TAV-in-TAV group.
So, I mean, the TVT data showed that there appeared to be a kind of signal for worse outcomes if you fractured before, but that was exclusively with Sapien. But I think, with Evolut, there's a very good chance that you don't need to fracture here. You'll get, you can maybe post-dilate to non-fracture post-dilatation to optimize expansion of the evolute. Then you could make the decision, and with this kind of true ID, expect there would be a minority of cases where there was a solid indication for fracture.
As long as you implant the valve high, like Nico showed us before, we need to implant it very high in order to gain the supraannularity of the valve.
But this is a good question. So maybe I'd be interested what people think about that, because if you think you are going to fracture, do you deploy slightly deeper in order to minimize the risk of migration or
I don't like
embolization?
deep implantation. I really dislike deep implantation. I think it's less healthy for the valve. We don't need to malposition our valves, but 2 millimeter depth is perfect for our valve.
I guess I'm talking...
And you have room for post-deal as well.
Yeah. I think, it's in our practice, if we had a non-fractural valve, trifecta Hancock, we would go super high, because if we had a fractural valve that we thought would fracture, we might go more like 4 millimeters rather than 0 to 2.
4 is good.
Okay, so
that's a very, very, very wise comment. Yeah. What we're going to do is to go for a remodeling, a reshaping of the valve after deployment of the Evolut FX Plus. So you will have plenty of time to describe the features of the Evolut FX Plus, but the novelty in comparison of the FX is the addition of 3 open windows beside the post to make sure that we get access to the coronary arteries. So Ole has nicely mentioned one of the challenges for this patient is to achieve a proper commissural alignment. So Nico, you move to the LAO projection, and what I'm going to do for the audience is just to rotate the handle and to bring, if you have a close look at the fluoro at the same time, to bring the heart marker towards the outer curvature of the aorta. So we're going to do it like that. We're going to keep it like that. That brings the flush port around 1 o'clock.
And let's cross?
Yeah, and we will cross like that, trying to keep the heart marker into the external curvature.
Yeah. So the second validation point, Didier, as you just mentioned, is once you arrive in the ascending aorta, to check still in LAO that your heart marker is now in the external curvature.
Exactly.
Okay for you if we cross?
Yeah. You may face this challenge,
exactly.
Nico. Something that we see from time to time is the horizontal aorta that sometimes brings a kind of difficulty in crossing because you are getting close to one of the posts. So what is the projection that we're going to use, Nico?
Yeah, it's as predicted by CT scan, and I must say sometimes you can have some discrepancy between CT prediction and what you get the day you do the procedure, but here it's quite comparable. So it's area 10, caudal almost 40.
Yeah.
You see that we have here, I think, a good alignment of the 2 S-curves through the one from the surgical valve and the one from the transcatheter valve.
Yeah.
So nicely seeing the alignment of the entity and also nicely seeing the alignment of a distal part of a valve still shift into a catheter.
Exactly.
And so I can record that maybe for
if you record that just for the audience. So we nicely see the landmarks. And another point of focus that we're going to have, guys, for you in Paris is the location of the 3 markers for the depth assessment, as well as if they are properly aligned with the commissures. So we're going to check that.
So as said, Didier, before we proceed, it was explained just before, but it's worth, I think, coming back here. What are we looking at and what is our target? So if we start from the aorta to the LV, looking at the surgical intuitive valve, we have a post, we have then the sewing ring, and then we have the steel skirt. So to be clear, our aim will be to position maybe 2-3 millimeters below the sewing ring, but we won't try to align inflow to inflow with the steel skirt because it would end up too low.
Exactly.
Let's try it.
So, Nicolas,
yeah, please.
In these anatomies, it's quite difficult to get perfect coaxiality between the TAVI device and the surgical valve. Is this something that bothers you, that you want to try and correct, or would you say no, it doesn't matter a lot and the valve will correct itself upon release?
It's something that we did try to correct at the start. You can see the location. It's a very important comment, Mo. The location of the wire that is deep into the left ventricle, more or less towards the outer curvature. And then at the end of the day, you have to deal with the orientation of the aorta. So the aim is to try to only focus on the non-coronary aspect of the anatomy. Here, there is something that is we have to keep in mind is the way the posts are distributed. They are not properly aligned. You can see the two posts that are locating towards the non-coronary side of the anatomy are a little bit too separated.
Okay.
So what we can do is to gently, this is another point of discussion because this is not required by the best practices, but what we try to do is to find the proper movement of the handle that is going to bring the markers closer. And you can see they're getting closer.
Yeah,
and I think
regarding
it's,
the depth, Didier, let me record that for our colleagues, but I think it's quite high, but it could be okay. So maybe we can pace 160. Okay, you see the ECG, we have a good capture. And let's go.
So let's do that first attempt here, and Claire is going to decrease slowly until 40, let's say 40, diminue jusqu'à 40.
Yeah.
And I like the commissural alignment in that projection.
Yeah.
So I think it's really important to work on that because we are trying to make sure that we keep the door open for any subsequent procedure. And achieving a perfect commissural alignment is important in contemporary practice. And we can do that with any kind of TAVI device. So we have to work on that.
So Didier, what we can do is let me work a little bit on the alignment here. I think it's good because what I personally want to see now is the relationship between the three dots that are, for me, an easy way to visualize my depth of the Evolut within the surgical valve and respective to the landmark we define, which is the surgical. So let me record that without injection. And my goal here is to ensure that I will have my three dots really below the swing ring before to release, and of course not too deep. So what do you think?
So what's your opinion, guys, in the panel?
Looks good.
I mean, it's an advantage, as you mentioned, of this modified version of the FX that you can now see a little bit something on the stent frame, because otherwise I can imagine without these three dots, it would have been difficult to anticipate or to understand where the inflow of the valve is, correct? But on the other hand, I'm not sure whether we can 100% assess the depth. Yeah, exactly. So I would try and move it a little bit and try maybe to get these on one line in order to understand a little bit more the depth without parallax.
Yeah, I think, I mean, for me, sorry guys, brief, I mean, your rotation in the we've got Medtronic people on the front row here. I think a few of them a bit sweating a bit when you did that, because we should say that that's off-label, but I mean, I think it's something that's interesting, and obviously we're going to learn from you how that works, but maybe a disadvantage is by overlapping the dots which align to the right and left right and non-coronary cusps. When you're in the cusp overlap view and you move away from it, you don't know which dot matches the non-coronary cusp, whereas if you're in a true cusp overlap view isolated non-coronary,
so let me,
then you know exactly which dot matches non.
we stay in the cusp overlap projection, Dan, in fact, when we rotate within the anatomy. And in fact, to be honest, you can do it with any kind of self-expanding platform. It's not a new technique. It's something that hasn't really been tested for the Evolut, but it works. It requires a little bit more of torque because of the constitution, the features of the catheter, the way it's built, but we may apply an appropriate rotation on the markers. And you are totally right, we have to stay in the cusp overlap projection to see how the markers approaches themselves, and you can see that in that projection. And that's something that we're going to learn more and more, but it's achievable with any self-expanding valve, in fact.
Didier, just one last comment, and for you and for our colleagues in the audience in the room. In this projection, if you focus on the left part of the Evolut and the shape, we have this kind of belly shape that sometimes we don't like a lot, and we see that the dots are just borderline respective to our target. So what do you think on that? Do you think we're still on the safe side, especially if we want to go for a post-deal, or do you think we would need to have maybe a safer margin?
That's a critical question. Maybe we can review the...
I'm sure you will have different opinions here. So I anticipate Danny will say it's good. I'm more a little bit on the safe side as you, Nicolas. I would say maybe I try it once more and maybe get it on the... Yeah. No. That's not what I mean. But I know how you think. So I would say maybe try to get it a little bit more coaxial and get rid of this belly on the non-coronary side. But this is my opinion.
Yeah.
I'm sure the panel, among the panel, are different opinions as well.
Maybe we can do several cine images in like hypo. Zoom in just to understand a bit better because.
I think it's okay. I mean, I think for me, you get a little bit, you are getting support from the posts and the rest of the structure as well as the sewing rig. I mean, I wouldn't advocate ever going above the sewing rig and relying wholly on the posts, but I think here that there's enough support to deploy the valve.
Nicholas, what?
So let's we're gonna.
Yeah, I think
reshape.
you see this belly shape on the left side.
Yeah, I think it's wise
so.
to reattempt this. So you did a mechanical expansion in a way. And I typically do 3 projections. So the coplanar view, the cusp overlap, and then also an LAO view to confirm each separate cusp. That has been an adjustment in my practice. But basically, this is a modification to what the guys in Toulouse are doing right now. I think this looks good, at least at this projection. So I would add 2 more projections to make sure that every cusp is.
This looks better,
so
I think.
We need to check in various projection.
Yeah, you're good.
The free cusp coplanar.
Yeah.
And it's more coaxial as well.
I think so.
Yeah, it's more.
Yeah,
reassuring.
I think so. It's more coaxial. Exactly. And I think if you come back to that, look at that one, and maybe look at the previous one. And I think we got rid of this belly shape that we had.
Slightly,
and we are a little bit more coaxial. So we would be more comfortable to release it here.
You always have the blessing and the curse of the retrievability, repositionability of the system, because, to be honest, also the first one was good. Both are good.
And quite importantly, once again, we see that the commercial alignment is still good.
Yeah.
The dots are really nicely located in relation to the post, so that's very important as well.
Exactly.
Okay.
But, this is a common...
Please.
No, I was good. I mean, with all Evolut cases, this is a common scenario, making that decision before release. And I think, even though I thought it was going to be okay, you have to ask yourself, well, what's the chance of it migrating or embolizing, And what kind of chance are you prepared to accept? And if it should be almost 0 because embolization is catastrophic, whereas recapture and redeployment is straightforward, And I'm not saying it carries no risk, but it's close to no risk. So I'm sure this is sensible.
Releasing the valve, as you can see, they're doing it extremely slow.
Exactly.
You have
That's
time.
very important, Mo, and I think, we have
extremely
time.
slow, and for that part, I must say, I let Didier handle and manage this part of detachment and the management of interaction of a nose cone and a wire.
Let me just replace the Safari. Yeah. Perfect.
Good. So let's come back to our home view.
I like the comment from Mo, and most of the time I have the feeling that people go too fast for the release of the outflow.
Yeah.
And that explains some of the uncontrolled final movements.
Probably.
And normally we should get rid of that.
Yeah. So Didier, will you just pull back the catheter?
Look at the dots.
And I'm going to record that while we're making the shift.
It looks to be at a perfect height, perfectly aligned.
Looks good.
I think as usual, again, it's a usual scenario in this setting. We had, once the valve was released, a tilt that finally compensated the discrepancy between the depth on the 2 sides, left and non and right. But what is nice here, I think, is first the depth, which is what we were aiming at, Didier.
Yeah.
And the commercial alignment, I think. And if we properly look at the dots, I think we are at to some degrees, but we are more or less aligned with the post of a surgical valve.
So are you going to post-dilate this immediately or not?
Not necessarily. That's a good question.
Yeah.
Let's check the hemodynamics first and then all decide if there is a need to. It's all about the expansion of the stent frame, and we already have the feeling that there is a metal-to-metal contact. Yeah. That we don't have these very thick leaflets that prevent both edges, outer borders of the Evolut and the fail Intuiti to connect, to be in contact. It doesn't seem to be the case here. So let's, Nico, maybe let's record the hemodynamics and then we will all decide with our friends.
And I think here we are in an anatomical situation or in treating a surgical valve whose size is not per se, I think, indicated a preemptive BVF.
Yeah.
because it's not too small one. So I think you really have to adapt and to tailor to what you measure. And this is one of the advantage of trying to decide to do it afterwards. Because then you can decide whether it's something useful, necessary or not. So let me flush all the pressure.
I have to say that in our practice, we usually post, unless we're really worried that we're high, we'll post-dilate, then do the hemodynamics. I think even if the hemodynamics are good, there is some case for that. There's still jury's still out on the durability of TAV and SAV, and maybe optimizing the expansion will contribute to better durability. Even if the hemodynamics are satisfactory. So I think that's what we tend to do, even if and as long as we're not too concerned about the height, we'll post-dilate, then do the hemodynamics, then decide about fracture.
So it appears you want to post-dilate?
Yeah, because there was a slight gradient, and usually we don't get a peak-to-peak gradient. There was about 5 millimeters of mercury, and we know that if you do the echo the next day, it's going to be greater than 15, that. So it's better to post-dilate and make sure that we get close to 0 millimeters of mercury during the procedure.
What balloon size and type?
It's going to be a 22. So the idea was 20. We're going to do 22 just to try to maximize at least the dimension of the constrained portion of the Evolut FX Plus that houses the leaflets. Just to make sure that we really take advantage of the supraannular function of the device. So it's going to be 22, Danny. 180 là, du coup, Claire.
So let me reconnect to pace. It's okay. Didier, give you a syringe.
Et la pince.
Okay. I will be, it will be fine for me here.
And you're going to push forward?
Yeah, exactly, as usual, in order to hold everything really stable. So pacing on. I will tell you.
Yeah.
Okay, you can go. Balloon up.
Descendre un peu.
Fantastic.
Attends. Just pace.
Okay, we keep on pacing because
there was a disconnection of the syringe.
Disconnection of a syringe. And pacing
off. Thank you, Melo.
Good.
Okay. So let's withdraw that. Even for the withdrawal of the balloon, sometimes it's in a kind of parachute configuration, and so it's better to...
And I let it play again for you while we're putting everything in place to remeasure the hemodynamics, because again, it's totally subjective and not something we quantify here, but you see a mechanical action, or a stretching on the overall system, especially at the level of a post of Intuiti, where you see it's opening. Of course, we have some kind of recoil afterwards.
Yeah.
And for sure, we may have applied some pressure to better expand the Evolut inflow. So let's record.
But what we just watched during post-dilatation, I think this is extremely valuable, extremely educational for maybe a lot of the participants, maybe who do not have your experience. Because, I mean, it can happen that during deflation that the syringe detaches. And the most important thing, and you can see here how they remained calm, and they continued pacing, which is extremely important. So we have to continue pacing and then deflate the balloon. Because if you stop pacing at that time point, you really risk embolizing the valve. So very, very elegantly done, very educational.
Thank you, Mo. So let's focus now on the hemodynamics. So there is no more gradient. It's almost kind of inverted, so it's 0, in fact. Let's remember the end-diastolic aortic pressure that was 42. It's exactly 42. So we have exactly the same hemodynamic status at the start and right now. So we can really appreciate the true hemodynamics. The LVEDs was 13. It's 14. So hemodynamic-wise, I don't have the feeling that we have anything additional to do.
I don't think so, no. Okay. Do you want me to withdraw the pigtail for the final angio, or you want to do it with the pigtail?
Maybe we can withdraw the pigtail. I think we're good now.
Didier, I want to ask you something on this pigtail coming, I think, from the left radial artery, correct?
Exactly.
We didn't see you using it at all. Why are you? Why did you insert it?
Yeah, it's true. It's a good
Yeah, it's
question.
true.
We
It's true.
we could have even avoided to put it.
Yeah, from time to time for the disvalve in valve cases, we
Yeah.
only use barely one access, the main access, and you can do everything with a single pigtail.
It's mainly for the final angio, and that's it. And it's okay for you to inject? Yeah.
Amazing.
Beautiful, yeah.
Okay.
Yeah, it's nice.
There we are. So very important. Thank you guys. But I have to say that we maybe you have the focus on the depth, and my focus is on the commercial alignment, and I think it's really nice. And
It's nice we focus on two important points.
yeah. So this is where we are. I guess we can go for the closure. We can do it live.
Yeah.
So it's going to be a Nico, a single ProGlide and an angio-seal. Do you want to withdraw the Sentinel just to see if there is something inside?
Exactly. Maybe let's do it. Okay.
So it's true, Dan, we heard your comment and the fact that there aren't any solid data confirming the usefulness of cerebral protection devices in the general population, and Danny said so. But we do believe that for sometimes complex valve-in-valve cases, the same as, tu peux regarder à l'intérieur des filtres, merci. Same as bicuspid or extremely calcified valves, sometimes it's empirical, but it may be useful to use a cerebral protection device. Here it was a new surgical valve with not a big amount, a big load of experience concerning it. So we had the feeling that potentially making sure that we have an additional safety net stroke-wise was appropriate for the patient.
Okay, good.
And your strategy of closure using one ProGlide or ProStyle and one angio-seal, this is your routine strategy, correct? Any exceptions
exactly.
when you use something else?
Maybe I would say, but maybe we have some slight differences between Didier and I. But the few cases where I come back to the two ProGlides technique is maybe for the 34 valve sometimes, or a 29 for balloon expandable, or in other words, when I upsize my entry sheath. But not all the case, not frequently. So yeah, it's really routine strategy for us. And what is nice is that you saw here once we tighten the first ProGlide, we insert the sheath of the angio-seal, and this is a crucial step because now at that step we assess the amount of bleeding around the angio-seal sheath, and in case we still have some residual bleeding. It's still time, if needed, to withdraw the sheath of the angio-seal and to come with a second ProStyle, or even if the bleeding is really, really huge, to change your strategy and to come with a manta, for example. So it's really something that you can adapt. And what we have changed and what we're doing also routinely now is to assess the final outcome by echo. So first without color, just to check for 2D visual assessment, and you have to be familiar if you do that with this image. You have at the top the roof of a common femoral artery, which is the collagen plug with some shadowing below, and then we put the color just to check for the flow below the closure location, and also in the subcutaneous tissue. Si vous montez un peu la couleur. In a subcutaneous tissue, just to be sure that you don't have any active bleeding in the tissue. But here it's
it's perfect. There is nothing, and it seems, Melo, that there is nothing within the basket. Oh, there we have something. Oh yeah, okay. Thank you, Melo. It's very important if we could do a close-up on this, because it's gonna feed the debate whether or not to protect the brain. And you can macroscopically see what we obtained within the filter. And this was within the proximal filter. So we don't have the data from the literature, but we have that. And Nick van Liggem is a strong supporter of that. He has published a long time ago about the fact that we systematically find something within the filters. So food for thought. The debate is still ongoing, but we do believe that for very complex cases, it may be useful to use a cerebral protection device.
Yeah, so thank you again, Nicolas and Didier, for an excellent demonstration of a complex case.
you.
You made it look so easy, so thanks again, and see you again during the upcoming live case from Toulouse.
Thank you.
Thank you.
Bye-bye, guys.
Thanks, guys.
So, Ole,
Yep.
I think in the meanwhile you've prepared some
Yes.
images from the procedure, and you want to highlight?
Yeah, very quick. Just as a recap, because they did everything state of the art, I would say. First, to start with, they started with the fluoroscopic check if their CT calculated angulation, fluoroscopic angulation was correct. What they wanted is indeed that one commissural post was isolated there and the two other posts were overlapped right here, which was the case, so the CT calculated image was correct. Then they proceeded with the case just to show that, here, the safari wire has to be positioned really correctly with the curve facing up. And that was very important because we know that the aorta is quite wide here in order not to face any problems crossing. Let's move this out of the plane. I want to get to the next one. Then for the commissural alignment. So what is the first important step? Of course, before crossing, they go into an LAO view. So here you see that actually this is an LAO view. You know that it's an LAO view because the aorta is opened. Yeah, so it's an LAO view. But you see that the head marker is not on the outside. Yes, you see that? So there, they had to correct for this. So they did this. And they turned the flush port here to, instead of 3 o'clock, to 1 o'clock. And by doing this, you see here nicely that the head marker could be placed on the outside. This is this part here. The head marker is on the outside. So having this, you can proceed, and then you can do the crossing. While you do the crossing of your aortic arch, I'll move it over here, it's important that you keep an eye on this head marker, this head marker here, and this has to go during the whole transition over the aortic arch on the outer curvature, okay? And arriving in your LAO still, your LAO view, is typically an LAO 20, 30 degrees, you still want to see that head marker on the outside. It has to stay on the outer curvature. If that's all the case, you're typically gonna be good for your commissural alignment. And you can double check that now in your cusp overlap view, and this is the commissural overlap view, yes, the REO caudal view. They indeed, if you zoom in on this, I don't know if I can zoom further on it, but you see indeed that there are, the head marker is now in the center, yes. So it's actually what you have is this marker band with here the head marker on the bottom, yeah, like this, you see that. And then on top of that, you also see that they have two dots kind of overlapping there and one isolated dot there. Yeah. So that's what you want to see in the cusp overlap view. You want to have the head marker in the center. You want to have two dots of the markers on the left-hand side, one on the right-hand side. Then you know you're good for your commissural alignment. Okay. Then going to the final implant, a couple of steps there of importance. Again, they start out, we know that this was kind of the virtual new plane where they wanted to aim for. And as you see here, they wanted to have these markers which are positioned there, they wanted to have that around this level, which they succeeded. Then, this is not according to IFU, but they did some manipulation of the catheter to optimize still that commissural alignment. They did that. But that's not recommended, to be honest. But you see during the expansion, you have these two markers overlapping here, one isolated there, and they aim for the correct depth. That's all well done. Then they proceeded, and there was a lot of discussion then for 1, 2, 3 minutes about, are we good for releasing the valve? Do we have enough depth, yes or no? You don't want to have an embolization up towards the ascending aorta. I think they were probably kind of okay. I think they could have released the valve and it would have been good. But you can see that they had some kind of asymmetrical implant depth. One of the markers is here, you clearly see. So that's around maybe 3 millimeters below. Here they have the markers nicely overlapped, and at the level of this bottom of that stent, it's surgical prosthesis. So there was some asymmetricity. Also, you see that big bulge of the valve. So that also lets you feel there's some stored tension in the stent frame. You can anticipate probably that the valve will, with the final release, will tilt towards there, and this will gain some depth. But in a way, they didn't want to take that risk. So in that way, they did a partial recapture. As you see, this is the way to do it. You can do it very quick. You do the pacing on, you do a partial recapture. The first operator added a little bit of extra push, and you expanded right away again. And by doing so, I think they got actually a much better coaxiality of the frame. Sorry, this is before still, I think. I will show you here. Yes, this is after the repositioning. You see immediately you don't have that bulge shape of the valve anymore. You see that the coaxiality is much, much better. And you have a symmetrical, this is now in tricuspid view. There's a marker there. There's a marker, it's hard to say here, but I think as I saw the markers, they were all just at the bottom of this surgical bioprosthesis. So much more better coaxiality, more symmetrical depth implantation, and in a good depth, also confirming in a tricuspid view the commissural alignment. And then they did, very important, I want to emphasize that, you see how slow they did the final release. This is also my way of doing. If I'm at 80% and I feel I'm at a good position, I go extremely slow. That's the slowest part of my whole procedure. Give the time to that valve to slowly, nicely deploy, come off with the taps from the catheter, and like that you have the least mobility of the valve. Yes, and then finally, I'm almost there. Then just to discuss the last ones here. The final result. So let's go there. Is the last ones. So first of all, they obtained the commissural alignment. You see here with the two commissural posts overlapping, they also have the two markers and one marker there. So they have perfect commissural alignment. So that's great. We discussed this, that it was important for this particular case. They did for Post-dil. I fully agreed. I think 98% of all my valve-in-valves, TAV-in-SAV, TAV-in-TAV, are always post-dilate. There is even some data on that you have better hemodynamics. So I think if you think there is no risk connected with it, you should probably do it. And then here they also see, you saw that the hemodynamics, in the beginning they had some separation. That hemodynamics became great. And then here, I want to show that then there's no PVL. That was great, but especially this one is still interesting. You can actually see in this overlap view that here you see these big windows. Yes. So here you see the big window of the Evolut. Yes, you see that. How can you see it? It's sometimes hard to see it, but the trick is, well, that if you overlap two of the markers here, if you do the commissural alignment of your Evolut valve, you start to see indeed, then you have this window, you have two windows. You look through two windows, yes? So you see how large they are, and they're exactly, we know that the left main, for example, is at the level of here. For example, the right is even higher. Yes, so this will not be any issue to get into the coronaries. Okay, so I think they had a real great optimal result, perfect implant depth, commissural alignment. They obtained what they had, great hemodynamics, so great treatment for this patient.
Thank you, Ola. This was really wonderful and I mean, this bridges us actually very nicely to Danny's talk. I mean, you can see here that this was a 78-year-old patient. He now has two valves inside each other. It may be necessary at a certain time point, even if the necessity is probably, like, from a statistical aspect low, as we heard from Nicholas, but the patient may need the third valve. So he may need a ViV TAVI. And now we recently have a CE mark approval, or like an expanded indication for Evolut for ViV TAVI, but it's probably also a different animal. Danny.
Absolutely. So, do you hear me? Yeah, perfect. So ViV TAVI planning and in general, the topic of ViV TAVI is one of the most important topics in the TAVI field, I'm sure. And why it is so? We know that TAV in TAV, doing TAVI in failed TAVI devices is going to be very common, and it's going to be like that very soon. The number of valve-in-valve procedures is probably going to be around 5 times the number of valve-in-valves that we do, and it will consist mostly of doing TAVI in failed TAVI devices, much more than we do TAVI in surgical valves that failed. So we must understand TAVI in TAV well. We must know how to do it perfectly in order to improve our patient's life. And in general, for the TAVI landscape, with the potential adverse events that can happen in different procedures, we can dichotomize or look at it in a different way. We are doing it TAVI for conventional native anatomy. We do TAVI in stented surgical valves. We do TAVI in stentless valves. And we do TAVI in TAV procedures. And for each type of procedure, we have different potential risks. For instance, for TAV in TAV, the risk of malposition is not so high. PVL is not so high. Annular rupture is not so high. But residual stenosis, probably there is some risk. Coronary access, more challenging. Coronary obstruction risk can be more a higher risk. So these are the challenges with TAV in TAV. And if these are the challenges with TAV in TAV, we can decide together what would be the priority when we do TAV in TAV. In general, we want to identify whether for our particular patient there is a coronary obstruction risk. More common for TAV in TAV than in general valve-in-valve procedure. We need to optimize hemodynamics, like we want to optimize hemodynamics in small annuli and in valve-in-valves in general, because that population is more prone for suboptimal hemodynamics. We want to maintain coronary access, and obviously we want to prolong valve durability. These should be the priorities for TAV in TAV. Very short presentation, so I do not have a lot of time to discuss the different concepts, but when we talk about the risk for coronary obstruction, we need to understand that there is a plane where the coronaries emerge, and there is a plane where the neoskirt that is pinned laterally can cause coronary obstruction. And it is all about the relationship between these two planes, the neoskirt plane and the coronary risk plane. Because if we know that the neoskirt plane will be deflected below the coronary ostium, then there is no risk for coronary obstruction. We call it type 1 anatomy. If the neoskirt will go above the level of the ostium of the coronary, then there is a potential risk, and we need to measure VTC and to see whether the VTC will be below 4, and then it is at risk. If the neoskirt will go above the level of the STJ, and not only above the level of the coronary ostium, then it's a different story, and we need to measure not only the VTC, but also the VTSTJ. We need to understand whether there could be potential leaflets, sinus sequestration. Sinus sequestration is obstructing all the flow to that sinus and the coronary obstruction. And by using these tools, clearly we can identify whether our case is low risk or high risk for coronary obstruction. This is the most important step to prevent coronary obstruction. Not doing leaflet modification or chimney or that, but to understand whether our patient is at risk or not at risk. And also not doing extra methods and tools that are not necessary sometimes. We also need to define, it didn't come enough in our session, whether our index TAVI device is well expanded. Because when we implant a perimount 23, we know that this is a perimount 23. It has a certain diameter, it has a certain height. But when we implant a 23 Sapien 3, unfortunately, we know the truth that some of them are severely underexpanded, and this is why they came back to us with a failed Sapien 3. And we need to understand the index TAVI device expansion, because in these certain situations, we want to expand the valve. We want to do pre-deal, aggressive pre-deal, in order to prepare the area for the second valve, in order to have better expansion, to have better durability later on. We don't have a lot of science in the field of TAVI in TAV, but we know that there is hemodynamic benefit for using supraannular THV devices in failed intraannular devices. It came up in certain publications, and I encourage you to read it. So in general, when we talk about TAV in TAV configurations, short frame devices, long frame devices, we can say in general that when we have a failed short TAVI device, there is an advantage of doing supraannular TAVI device implantation in order to improve hemodynamics. And in some way, in a failed tall TAVI device, we want to use a short device in order probably to improve coronary access in that particular case. But obviously, each case, it has its merits and situation that needs to be discussed. So one slide of summary, TAV in TAV planning, we need to ensure the procedure indication. Obviously, not doing it in endocarditis, but also not doing it when there is valve thrombosis, when there is a isolated paravalvular leakage or underexpansion, situations that could be treated in a different way than TAV in TAV. We need to obtain as much index procedure information, the original angios of the case, the pre-index TAVI CT. We need to do CT analysis for the redo TAVI procedure. We must identify the risk for coronary obstruction, pre- and post-deal considerations, the threshold to do pre-deal and the threshold, like in our case that we just saw, to do post-deal should be very low. We need to do in most of these cases pre- and post-deals. And we need to aim for optimal commissural alignment like we saw in the case. And we need to optimize second device type, size, and position. And we can say from science that supraannular THV allows for better hemodynamics in redo TAVIs. And we are very grateful and happy that fortunately now we have the option to use Evolut Pro Plus and FX because it received CE mark for the expanded indication of redo TAVI. So thank you very much for your attention.
Danny, thanks. That was an unenviable task, 6 minutes, which turned out to be less than 6 minutes on redo TAVI. But there is a session I'd encourage you to attend on Thursday, the same room here at 3 o'clock, all about redo TAVI and how to treat different types of failing prostheses, which you'll get a full overview. So I just want to wrap the session up before everyone dashes out the room. I mean, I think it was a great session. Fantastic live case, as always, from Toulouse. We heard about the different considerations in younger patients. First of all, from Nicholas, 70-year-olds will, on average, only have 10% of them requiring revalving, so make sure the first procedure is right before you start worrying too much about what's going to happen in 10, 15 years' time. But when we do treat these patients with long life expectancies, regardless of whether it's TAVI or surgery, they need to be assessed in detail before, CT in all cases, and then an informed heart team decision about the options of surgery or TAVI, and then if we come to TAVI, which kind of prosthesis. And then we saw from the live case the amount of attention to detail and preparation in particular that's required when performing TAV in SAV to get an optimal outcome like the one we saw today. And with TAV in TAV, we're learning a whole new process, but again, emphasized by detailed preparation, understanding of the valve you're treating, using the support we can get from the app and other resources to get an optimal outcome. So we'll see you on Thursday where we can talk more about redo TAVI. Thanks for your attention.